home and abroad. Assalamu alaikum, good evening, good morning. It's my honor to welcome you on behalf of Public Health Cafe. My name is Qazi Mohirul Islam. I am former Director General of Family Planning in Bangladesh. I will be moderating this webinar with your kind support and cooperation. And this webinar is organized by Department of Public Health, College of Nursing, IUBAT, Public Health Foundation, and Health Systems Matter. Today's chair is Mr. Alex Barland. He is health system expert and founder of Bangladesh Health Project Canada. He has more than 52 publications, author of many books, and reviewer of several publications and mentor of several students. And we have a key presenter today, Ms. Zahin Rahman from University of Saskatchewan, Canada. And we have two notable panelists. One is Mr. Saiful Islam from School of Public Health, New South Wales, Sydney, and Ms. Mary Ann Morris from University of Victoria. She is co-founder of current board member of 𝗱𝗲𝗯𝗁 Canada, a non-profit volunteer-run community health organization, works with wellness options. And we have more distinguished participants. I cannot mention the names of each and every one, but all are dignified, all are honorable participants, and and the students of the MPH and other colleges of IUBAT and other participants, you all have enriched and made this webinar dignified. So we'll listen to the presenter first, and then we'll listen to the panelists. And meanwhile, you may have some questions. You can put the questions in the chat box, but there will be a separate question and answer session. If in your chat box we are unable to answer all the questions, then the question answer session will be able to interact with each other. So we want to record the documents, the insights, the suggestions, and that's why we need to record this program. I hope you allow us to record the program. And now I would request Zahin Rahman to present our presentation.
Great, thank you. I think I need access. Oh, I already have it, sorry. Can you see my screen?
Yes, all good.
Okay, so hi everyone, assalamu alaikum, namaskar. I just want to give a little bit of background about myself before I start because, you know, most of you don't know me. So my name, as I was introduced, my name is Zahin Rahman. I was born in Dhaka, Bangladesh, but when I was, say, 2 or 3 years old, my parents and I immigrated to Canada. And so I've been, you know, living in Canada for all my life, and I've completed all of my education here. But as I, you know, continue my academic pursuits, I would like to be more involved in projects relating to Bangladesh and how we can continue to develop our country. And so when I did this project, I thought it was really interesting, this project in Uganda that I'll discuss today. I thought it was interesting because I found a lot of similarities between Uganda and Bangladesh. And I thought, you know, it'd be excellent if someone could implement a similar project in Bangladesh. And so that's just some background on myself. And I'll get started. So this project, sorry, my cat. This project we've titled Women and Youth as One Health Champions in Isingiro district in Uganda. And now this was done under the supervision of Dr. 𝗱𝗁𝗂𝗏 at the University of Saskatchewan, who is, you know, one of the leading, very renowned and respected professors in the College of Veterinary Medicine in my university. So before I talk about the project specifically, I want to talk a little bit about the concept of One Health. Now, we had an excellent speaker, I think last month, talk about One Health. And so I don't want to, step on her toes too much because she did a really great job. But just for, I guess, review, One Health can be described as the aim to emphasize the aim to emphasize the interconnected nature of human, animal, and environmental health, but more so in practice rather than a definition. So I think of it as a philosophy or a framework to go about different policies or projects, etc. So One Health aims to recognize that health risks cannot exist in isolation. In fact, they emerge from systems where people, animal, and the environment interact daily. And this is especially visible in contexts shaped by climate change, land use, food systems, etc. So like Uganda and also Bangladesh. And now for me, what distinguishes One Health from traditional public health approaches is its emphasis on collaboration across sectors and disciplines, which I think is becoming increasingly important in a globalized world. And so I really appreciate that about One Health, but also it's focused on prevention rather than response. So instead of asking how we treat disease, and also at the population, like individual or population level, once it appears, One Health aims to ask, what are the upstream conditions that have created these risks in the first place, and how can we address them? So that is a little bit about One Health. Now, onto the project itself. So this is called the One Health Community Partnerships Project under, as I said, the University of Saskatchewan. And so essentially, this is a collaborative transdisciplinary initiative through the College of Veterinary Medicine, and it's funded largely by Global Affairs Canada. So it has a very nice and stable funding source. So at its core, this project aimed to improve community health while also promoting equitable One Health empowerment for poor and marginalized rural smallholder farmers. So it had a deliberate, like its main goal here is to improve community health through the framework of One Health, but also it aimed to focus on women, girls, and female-headed households in regions where zoonotic disease and human-animal environmental interactions are most pronounced. So the project is currently active in 3 countries in sub-Saharan Africa, in Ghana, and then in Uganda as I went, and then they're currently starting to do some work in Ethiopia as well. So this reflects a commitment to, kind of different, geographically different rural contexts in sub-Saharan Africa. And I want to know, a real defining feature of this project is its gender transformative approach, aligned with one of its funders, the Canada Feminist International Assistance Policy. So this means that activities are designed to not only improve health outcomes, as I said, but also to address different structural barriers faced by women and girls, to therefore hopefully expand their participation and leadership in their community's health and developmental processes. And so to summarize here, the purpose of this project, as I've outlined, is perhaps most importantly to build community capacity to manage different health outcomes, or different health challenges, especially, sorry? Can I continue?
Just background
You
noise.
go ahead. You go ahead. Yeah.
Please go ahead.
So, that's, I'd say, most importantly, the goal here, especially as we see an increased rate of zoonotic diseases after this most recent pandemic. Secondly, to empower women, girls, and youth as, generally speaking, marginalized groups in these rural settings. And then lastly, to strengthen One Health literacy and resilience such that we can mobilize community members to continue to teach what we taught them and, pass knowledge from generation to generation and community to community. So it's more than just a workshop. So why Isingiro, Uganda particularly? Like, why did we choose this location? So there are 2 main reasons. In many, like for background on rural settings, and I think a lot of you already know this coming from Bangladesh, But in many rural settings, households rely on really unsafe water sources, live closely with livestock, and also therefore face high burdens of waterborne and or zoonotic diseases. So this photo that I've shown here illustrates one of the terrible water sources we encountered in Uganda. And just by looking at this water source, you can see how this community might have a lot of health challenges because this was their only water source for a little village any particular gram in Bangladesh. So Isingiro district is a really good site for this type of work because, as I said, it's quite vulnerable. It's climate vulnerable, it's livestock dependent, and also has limited access to safe water. But at the same time, its strengths lie in the fact that in this district, schools have been found to be highly receptive to practical health programs. So this makes One Health education both feasible and impactful in this location. And then also in Uganda, in all of Uganda, but also specifically Isingiro district, gender plays a very important role in why we chose this. So women and girls in these places often manage things like water collection, hygiene, and livestock support. So by incorporating a gender transformative component, we aim to strengthen the people that are already shaping household health outcomes in Isingiro and support more sustainable day-to-day practices and empower them to be, recognized as the leaders they really are in their communities. Because though we don't address this directly in Uganda, women make up a large part of the the informal economy, but aren't recognized formally for their contributions or really socially. So not monetarily or socially. So our idea with focusing on women as change makers, as leaders, as I outlined in my first slide, is to really empower them and let the community know that these are key leaders in their communities that already do so much and have the potential to make much more really tangible change. So moving on to the methods of our project, here's just a brief outline, but I'll go through these 4 components one by one and show you some relevant pictures. So starting with our approach, as you can imagine, we used a really participatory community-based model because as people who are not from Uganda, as Canadians, we don't know the nature of their living, of their communities, of their society. And so we thought it was absolutely essential that we work with the stakeholders to develop everything, as I'll discuss soon, because we have such limited knowledge. And I think it's really important, especially as North Americans trying to do this type of work, international development work, that we recognize that we are very limited in perspective and we don't know everything. And then also we tried to make sure that when we were developing a One Health, education curriculum, we looked at what they were already taught in schools, and I'll discuss that a little bit more, but we tried to make it so it fit the Ugandan context instead of, for example, the context in which I learned about One Health, which was as a Canadian student, a Canadian university student. So those are quite different contexts. And so we really wanted to make sure that we had the mindset of catering to our audience exactly and changing what we wanted to teach them based off of their, different contexts. So moving on to curriculum development, which was, a major piece of our methods. There was an established One Health framework, I think, created by the Government of Canada or Global Affairs Canada, some official Canadian document. And so we use that as a baseline, but we adapted that curriculum based off of conversations with our local Ugandan partners. And so part of that included changing language and vocabulary to better suit the fact that these students are not native English speakers. We changed some things where, some examples to better suit Uganda. For example, there were some mentions of medicinal trees. So then we would research about a tree with a similar effect and use that as an example. And then also a lot of the concepts in that previously established One Health framework are a little bit high level for young students. And then if we compound that with the language barrier, it was going to be really difficult to convey everything, especially at this level and with the limited resources we had. So that's all to say, here's a picture of us meeting with the headmaster and different teachers of a school. And we did this with each of our schools to understand, the average socioeconomic situation of each of these children, or like these groups of children, understand the range of ages they have in each of these classrooms that we were going to work in, and basically understand how much we would need to change our curricula based off of each group that we were working with. So moving on to the implementation of our workshops, after, we tried to do it with the younger students, we tried to do it with primary 4 students. It's very similar to the education system is similar to Bangladesh. So I think, they have O-level classes, and that's what we focused on. So after some, experimentation, we decided ultimately to work with the highest grades of those O-level schools. So we worked with primary 5, 6, and 7 classes in 5 different primary schools. And then we did 3 workshops per class. So the first being an introduction to One Health and essential concepts, like understanding that if a animal is sick in your household or in your family unit, that can directly lead to sickness within your family. So these types of kind of, essential concepts. And then secondly, we worked on water, sanitation, and hygiene, which they knew a lot about, but it was more about like specific details and how to maintain water, sanitation, and hygiene in settings where there's limited access to water. And then also we discussed menstruation in that workshop. And then lastly, we worked on essentials on first aid. Sorry, I just need a glass of water. So that was our workshops. And of course, we did a lot of research. We referred to the Canadian One Health curriculum while we were designing this. And then we came up with those workshops, and then we delivered it, the 3 to each of the P5 to 7 classes in each of the 5 schools. And then the last part of our implementation was we came up with a particular document that's outlining the rules and like I don't want to say constitution, but the background to create a student-led One Health club in these schools. And so I'll discuss that, but ultimately that was kind of a takeaway project for them to hopefully see what they can do with the information we've given them. And then we have students coming this year in 2026, and they'll go see in those schools what's been done, if those clubs have been effective, if the momentum has been continued, etc. Or maintained, I mean. So lastly, on methods, I'll talk a little bit about data collection and analysis. Now, I should note, as you can probably already imagine, one of the largest limitations of this project is that the data collection and analysis, it's pretty much all qualitative. Now, I have some numbers later, but the fact that we already don't speak their language and we're foreigners and we don't have quantitative ways to measure change, I recognize is quite difficult. But regardless, we made observations as facilitators. So like I was in the same classrooms. I taught, I think, 4 classrooms 3 times each. So I learned about my students and I could make observations and I could see if my students were engaging what I was teaching or if they were completely lost. And so those were a big part of our data collection. But also we had pre and post workshop evaluation. So we would ask a particular set of questions before each workshop and just roughly, again, not very quantitative at all, we'd roughly gauge the students' response. And then we'd ask the same questions. For example, what is One Health? After the workshop, after that particular workshop, and then we'd gauge the students' responses. And then at the end of all of our workshops, all of the three, we had one final session where we did student surveys, and an evaluation where we got each student to write down things like their favorite session, what was the most important thing they learned, as well as feedback, which I'll get into, feedback for us as facilitators. And then, of course, when we sat down to look at everything we had collected and what we'd done, we tried to maintain an interdisciplinary approach. So, for example, I've studied physiology and pharmacology, so I have that background. One of my colleagues was just completed nursing. Another colleague of mine was studied vet med, so she was a veterinary doctor. And we had a political science student who was very involved in things like leadership and women empowerment. So we really tried to maintain this perspective as we tried to look at what we hopefully achieved, which leads me to my key findings. Sorry, I need another drink of water.
Jahin, you have 5 minutes more time.
Okay, that's okay. I'm wrapping up. So, our key findings, we found that we had over 900 particular individual student facilitator interactions, which was a really large number. We were shocked. We found majorly that teachers really supported the delivery and translation of our programming. So by teachers, I mean their homeroom teachers, like one P7 classroom, their teacher sat with us as we did our program, and that was so helpful. And also we found it was really helpful to maintain engagement with the students by having the same facilitator for each of the three workshops. So at this school, in this picture, for all three workshops, I was with them, so I could build a relationship with them as their teacher, and they trusted me, and they looked forward like Teacher 𝗍𝗍's coming. So we found overall, in relation to learning outcomes, we did find that there was some improvement in the understanding of One Health concepts. So again, this is very qualitative, mind you. I saw within the students, internal discussions, they would talk about things like hygiene and safety practices. And I had observed instances where, for example, a student would tell another student, don't put your hand in your mouth, it's unsanitary, things like that. And then lastly, we found that students, and we found this largely at the end when we created those One Health clubs, we found that students were really eager to mobilize themselves with the information that they learned and take that information to their homes and to their communities to do something with it. So briefly, the lessons learned for me, I'd say, and for the rest of the group, are that building a relationship with those schools before going in and actually doing the programs is so essential, because it's important to create a relationship with the headmaster and the teachers. Having that same facilitator for each classroom each time really makes it that they receive you better, because if they have a different teacher each time, it's like meeting a new person, creating a relationship each time. It didn't work well. And then lastly, some challenges. Easily the biggest challenge was language, because we didn't speak their local language, and they spoke good, but limited English. That's not their language. That was big feedback from the students, is that we spoke too quickly, or we used high level language, or we pronounced things differently. And then also, naturally, it's a low resource setting, and in Canada we're used to all the resources in the world, so it was a bit difficult sometimes to convey things, keeping in mind that we should use what they have, because once we leave, this is all they have. And I've left some anecdotal reflections there that hopefully you've read. And so to conclude with the future directions of this project that other students will be completing this summer, we hope to refine school engagement by focusing really on older students, perhaps secondary school students, and then including more visuals. So students there, I think in Uganda, they often write on the board, which in Canada, I don't remember actually, because I'm in university, but they really asked us to write on the board more, especially because they don't understand English as we do. And then communication styles are quite different from student to teacher in Uganda than in Canada. For example, in Uganda, the teachers often teach things through song. And in Canada, as we get older, that's not really the case, I find. So we'll have to, learn these different methods to better engage with them. Um, I think, as expected with these young children, incorporating breaks but making them interactive as well as checkpoints will really help make sure that students are, on the path of learning as we hope for them to be. And then lastly, we want to, after, delivering workshops for hopefully another year or two, we want to evaluate the long-term impact, which we can't do quite yet until that's done. But then also, ideally, we would expand to more districts in Uganda or Ghana or Ethiopia, and then also develop localized resource kits. So that's like a funding issue where the community tells us they would benefit from X, Y, and Z resources. And we can hopefully, ideally, we would be able to come up with that for them and then give them what they're asking for, what they need, so they can thrive as a community and continue to use those resources as they've learned to, and really, sustain their community. So that is kind of the point of the project right now. Like, we are currently waiting to see what happens this summer. And that concludes my presentation. Thank you.
Thank you very much, Jahin Rahman. Very interesting things, very nice presentation. And one thing is very important, that you have used the locally adapted curricula that creates a lot of confidence among the local people, and the early school engagement is also very, very important thing. So we will be listening to the panelist, followed by the questions and answers from the participants. So at this stage, I would like to request Dr. Saiful Islam for his reflections on the presentation.
Thank you so much, Dr. Kazi. Thanks, Jahin. This is very interesting and innovative approach. My concern is that whether you have consulted with the recent Lancet One Health Commission report that has been published, I think, 2 or 3 months ago. That was a very comprehensive report, and it's focusing likely a little bit shift from the human-animal environment interface to the socio-ecological health system approach. I think this new approach, the socio-ecological health system approach, more aligned with the intervention that you are implementing in these countries compared to the prior human-animal environment interface. Because sometimes people got confused that One Health means only the diseases that transmits from animal to human, and environment means climate change, but the environment in the One Health context is considered more broadly. For example, in a family, if there is a bad or like conflicting relationship between husband and wife, it impacts the immunization of the children. So, but sometimes some people don't get it under the One Health lens. They think that One Health should not include this kind of things. But in a broader sense, in a socio-ecological health system perspective, actually everything, as you mentioned, the infrastructure, the local political situation, everything goes under One Health. And my second thing, I'm not sure how much you covered under One Health in the intervention. So because these are the students in year 7 or 6, right?
5 to 7, yeah.
5 to 7, yes. So you were right. Maybe you could use both English and the local languages in the pamphlet or in the whatever materials you have used, so that they can also understand these in their local language and also in English. That's the thing. And also whether you piloted this before implementing, I'm not sure. Maybe you have did it, you have done it before implementation
Actually, this was the pilot, interestingly. This was the pilot. I should
this
have
was
noted that.
okay, that's fine. So you already got some feedback from them, so you have the chance to modify. And this is really innovative. While you were presenting, I was thinking that why don't we do something in Bangladesh? Yes, it's very, as you mentioned, that the contexts are very similar, and if we have some champions from primary and secondary schools and in the colleges, so they will be our future leaders in health sectors or public health sectors. Okay, that's all from my side.
Thank you very much.
Sorry, do I address these or do we just hear different comments? I forget.
Do you want to make any comment after this reflection?
No, I just want to say thank you. I appreciate the feedback, and I think just briefly, if I can, we've discussed like just within my family, it'd be great to do such a project in Bangladesh, but currently there's like an issue of funding. So Global Affairs Canada, this is like a particular, like there's a large, I can't remember what it's called, but there's different streams of funding going to different projects based in Africa right now. And that's for a reason. I don't know what, because I'm not part of the government in that way. But I've looked into it, and right now there's not many Canadian Bangladeshi projects. I think they're focusing more on Africa. So funding is like a huge problem with that.
Okay, thank you. Thank you. We have another panelist, Ms. Mary-Ann Morris. Ms. Morris, can you hear me?
Yes, I can. Thank you.
Okay.
Thank you very much. That was fascinating.
Thank you. You have 5 minutes time, Mary.
Thank you. Firstly, can you please help me understand your background? Like you mentioned, there were people there who were vet backgrounds, nursing backgrounds. What is your background?
Me? Oh,
Yes.
Of course. So I, at the time that my friend had just finished nursing, the other friend had just finished vet med, and I just finished a bachelor's, an honors bachelor's in physiology and pharmacology. So very much body systems, similar to nursing, but more physiological than patient-based. Yeah.
I appreciate the presentation. Thank you very much for having me today. I really appreciate that you were multifaceted in terms of your perspectives and what you were bringing and how that would inform your various lens and interpretation of what you were seeing. I thought that was really interesting. I also thought it was really interesting that you had, from what I understand, done a bit of an assessment, not a bit necessarily, perhaps even more, of what the existing curriculum was. My understanding is, whether it's One Health, whatever it is, the latest lingo, we're wanting to base it on what already exists. So we're wanting to scaffold new learning on a foundational learning. And so I heard you say that given the significant problem of water contamination, there was some degree already of awareness that this was an issue and how to address this. So you were building on that. So I thought that was brilliant. I mean, it seems obvious, but it isn't obvious. And I think particularly when we come in from outside, we come in with great ideas and we don't necessarily build on pre-existing knowledge or understanding or behaviors. So bravo to you for that. I was a bit struck by 900 encounters. What was your time period?
So we stayed in Uganda for 3 months, which is already a lot longer than, these types of projects, because thankfully our project leaders recognize that just assimilating, I don't know if assimilating is the right word, but adapting to their country would take some time. So we conducted these sessions over a month and a half, and that 900 number is representative of, say, a student named John. I've met with him. Oh, there's John. I've met with him once in this first session, so that's one interaction, and then the second session I meet with him again, and that's 2. So that's the way we've counted that.
Nope, that's great. So I appreciate the timeline you were there. I think quite often we go in for very short, intense periods of time, and we think we know a lot, when in fact what we know is just a very small slice. So to actually be there for, I mean, I appreciate it's still limited, but a relatively longer period of time is also very impressive. The other thing that I was struck by was one of the things we've been both delighted by but challenged by. You mentioned teacher preparedness was one of the challenges, and language barrier. And I think that's frequently one of the issues. So teacher preparedness, was that as facilitator, your preparedness, or was that the local teacher preparedness as you shifted for them to assume ownership?
In fact, I'd say both.
Okay.
Good question. But when I wrote that, I was particularly talking about us as Canadians coming in. And this is more of a, I think, organizational issue for, our project managers to figure out. But because we're students and we're not, we're still developing our careers and learning about international development, we're certainly not perfect facilitators, but
for sure.
I think that was more a comment about the recruitment process and making sure that this is a big commitment to be in Uganda for 3 months and to commit to this project and give it your best every day. And so I think having people who have the experiences and particular personality and motivation to really adapt and really do their best is important, and it wasn't always the case. And I think that's particularly harmful as Canadians, because people already, we want to stay away from the savior complex. So I thought that, in my opinion, when we have facilitators going in and they've just read their notes before walking into the class, in my opinion, that's really disrespectful. So
one of the suggestions I would have to perhaps address that, and it might be interesting to discuss this with the lead, is if it's going to be more participatory and you're looking for empowerment, and you're looking for capacity building and agency development, then the methodology that you use is absolutely critical. Perhaps even more so than what the content is, because it sounds like a lot of basic content, whether it's water, sanitation, first aid, is going to be applicable. And it sounds like there's a receptivity to it. So that's amazing. So then it's methodology. And if the methodology being used locally is very participatory, like song, that's phenomenal.
Right.
We're used to talk. In my estimation and in my experience in Guatemala, not terribly helpful. So what we found with students going to Guatemala was really working with seminal books that are old, but man, they're still so relevant, like Helping Health Workers Learn with David Werner and Bill Bauer. I mean, that's that really engaging, animated type of learning, which necessitates that the facilitators have already developed a very participatory methodology before they even arrive. So it's not about their notes. It's about the sociodrama. It's about the songs. It's about the skits. And so I really encourage you to look at methodology. And the other thing I didn't hear, but I heard it with the idea of a club. I think that's fascinating, that the older students were the ones you found there was most potential to work with, and a train the trainer model. So as you're working with them, you're already saying to the 12-year-old, you are so significant in your family. How would you teach this or share this information to your brother or sister who's 6 or 7? So they're working with song, they're working with skit, they're working with drawings. And that club then enables them to continue to translate that information and then build on it so they become partners with you. I think that could be really fun. But bravo.
Yeah, thanks, Marianne. I like what you said about the methodology. I've noted it.
Yeah, great work. Bravo.
Thank you.
Thank you, Marianne Morris. A very interesting reflection. Now, our chair of this webinar session, Alex Barland, will listen to some reflection from the participants. Our chairman of Public Health Department, Dr. Sheikh Nazmul Huda, is here. Mr. Mahmoud Morsid is here, and other dignified personalities are also here, like Mr. Tapan Choudhury and professors from Public Health Foundation. So I would like to request you to raise any question or observation or reflection. And Alex, I think this part you will conduct. Over to Alex.
Thank you, Mohil. Yes, I'll just make a couple of comments while I look for some questions. You put up your hand on the screen if you like, or attract my attention. Thank you, Zahin, for a terrific presentation. Saiful and Marianne for your comments. This is exactly what we would be able to create with our public health cafe. You touched on many themes that are dear to my heart. This idea of collaboration and participation, of course, community-based engagement to lead us where we need to go, youth engagement, that we get the next generation involved in a significant way with these activities. So maybe I'll jump in here. I'll just go in sequence as the hands come up here. Mohammed Abdullah, you're first, please. Would you like to say something?
Assalamu alaikum. I am from College of Nursing student, fourth year student. So first of all, thank you for arranging such kind of webinar. I think I found a lot of learning beside academic learning. So the One Health concept I learned today. Before that, I don't know about One Health, and after analyzing the webinar, I found it's actually a very good concept, because it's very sustainable concept and it's a great concept. So I have several questions. First question is
just one question. Just one question, please, Mohammed. Just one question. That would be good.
Okay. So my question is in the in the presentation, I see that in the area there are female-based area mainly. So my question is, does that female-based community has any barrier to implement this One Health concept? Thank you.
I think there are several barriers because it's a low resource setting, but just to be succinct, in my experience, the biggest barrier they have is a lack of funding to have things like reliable water sources, access to just basic necessities like soaps and stuff like that. I'd say the biggest gap is funding, and they certainly have the motivation and desire to implement One Health concepts, but they just don't have the money to do so at this point, in my opinion.
Thank you, Zahin, and thank you, Abdullah, for the question. I'm sorry we didn't have time for more, but hang on to your questions, and maybe as we get to the end, there may be an opportunity. Mr. Chowdhury, welcome. Nice to have you with us, and please go ahead. You're on mute. There we go.
Yeah. Thank you very much. I enjoyed the presentation. I am more of an outsider. I'm the first time I'm hearing about it. I'm a retired public servant from the Ministry of Health, Government of Alberta, and adjunct faculty at the School of Public Health, where I met Dr. 𝗲𝗲. So I have always been a fan of quantitative analysis, because I'm a believer that what you cannot measure, you cannot manage. So Zahin, I liked your clear indication that it has been more of a qualitative analysis. The comments are of qualitative nature. And I think at this stage, that's perfect. But down the road, as you progress more and have a better handle on the as the project evolves, I think developing some metrics would be very useful. For example, 6 months ago, sort of before and after, there are how many people learned something, or how many people got involved into some health habits, and how they disseminated learning, etc. I think would be very useful. So it's a very generic observation, but focusing a bit more, whatever possible, measurable metrics. Thank you. Enjoyed the presentation, and thanks to Dr. Huda for inviting me.
Can I
Thank you,
address
Mr.
that
Chowdhury.
quickly?
Yeah, go ahead, Zahin.
So thank you so much for your comment. I really agree. And, I've made comments to my project managers about this, because I think we need to have to see evidential long-term change. It'd be great to have some quantitative measures, but I think that is not their priority right now. But I think like for that to happen, because I took note of quantitative things while I was in in country, but I was the only one because it wasn't an expectation. So the how do I say, the advice, or like the recommendation I gave, is that before facilitators even get in country, they're made aware of X, Y, and Z metrics that they have to note and keep track of, because like that wasn't at all the expectation for us. But I think if we have the idea that we're actually trying to collect data for some long-term analysis, I think that'll make facilitators take that more seriously, so we can, quantify what's happening here.
Thank you, Zahin. Oh, Professor Morshed, my friend from Vancouver, how nice to have you here. Your comments, please.
Thank you, and thank you for inviting me to listen to this great seminar this morning. And Zahin, thank you. It's very nice presentation. But I think that only I'll start with negative and then I'll say some positive things. I think that One Health is a good concept and kind of coined for many years now, but it's kind of still kind of going around in the developed country and developing country, establishing that the main barrier is funding. And funding, I mean that Zahin's presentation, that One Health mean that environment, human, animal, other surrounding things. But if you think about budget, 90% budget goes to the human, and remaining 10%, maybe 6 or 7% goes to the veterinarians, animal side, and then 1 or 2% here and there. So that disparity is one of the major obstacle, I think. No matter what you wanted to do, that is stuck there. So this is the negative side. And then also for doing the kind of research that Zahin is doing in Uganda, and it's true that there are some funding in African countries, because many investigators love to go there and do something. But I think that when things come for Bangladesh, I think it will be even more challenging, that who will go there, who will fund there. However, in Bangladesh, I think the model that Zahin showed would have a enormous impact. Enormous impact. I can give you particular example. As for example, you know that Bangladesh is experienced dengue virus or arboviruses like dengue, chikungunya, Zika, etc. for years, and people, 300, 500 people are dying every year, and thousands of babies and adults and older are getting infected every year. And it is not that summer month disease anymore, it's round the year. So, but that how we can control dengue. So there is a formula. Dengue is not a 1 year old disease. It's 100 years, century old disease. So we know a lot of it. But implementation, like the implementing using old people like me, will not work. We need to get to our younger generation, because if they teach their parents, that will be the best way for them to adhere to that system. So I wrote many editorials on news art papers that how to control mosquitoes. It's not a rocket science. controlling mosquito, I know it's challenging, but it's not completely could not be done, not in that mode. Like as for example, that if you keep people keep their backyard clean and use the mosquito net and know that when the dengue virus mosquito bite, if they know these three things and adhere strictly, maybe the impact will get much better impact. But I think that so many things can be done, and Zahin, that you showed us the way. But I think our friend living in Bangladesh should really carefully think it through, and that if need be, I'm interested because I was interested all along on vector-borne diseases because my specialty is vector-borne disease, and I'm with the BC Center for Disease Control, running the vector-borne program for last 3 decades, and I'm also clinical professor at the Department of Pathology doing the same thing. So this is the what I got from this lecture today, this seminar. So I think from this cafe, I think that for me is a good learning that if we could even develop the similar sorts of program in a more what should I say, kind of phased way, that this is the way that we can carry out and implement in village level or in even city level or even small town level, that certain neighborhood and do control in another neighborhood and see that what is the impact, and what Dr. Tapan Chaudhary is saying, that qualitative versus quantitative. So initially I don't mind doing qualitative way, and then we might go to the quantitative one. So I have so many thoughts, so I'll stop there. And thank you again.
Thank
Zahin,
you
would you
for your
like to respond? Yeah, go ahead.
Sure. Thanks for your comments, Dr. Morshid. I think those were very thorough, and I think, it's reflective of your extensive background in this type of, academia. I I I agree that I think having a really phased implementation-based similar project in Bangladesh could be really beneficial. And I think, these Bangladeshi academics who live in Bangladesh would know more about that than me because I don't live in Bangladesh. But I agree, and I think there's a lot of work to be done with this current model, but I'm glad it's a start, I guess.
Yes, I'll just briefly comment that in terms of engaging youth in Bangladesh, I receive every month 5 or more requests from young people, high school students usually, saying, I would like to volunteer with the Bangladesh Health Project. Professor John Richards on the call with me is our shared project. Young people, high school students, how can we volunteer? How can we participate? And sadly, I write back, I'm sorry, I don't really have a thing for you to do. But it indicates to me the level of interest by the younger generation in doing something. And we've just heard a very good description of some ways that we could engage young people in these activities. So I hope there'll be some local leadership, and that's always the challenge, is having local leadership, and maybe someone on this call based in Bangladesh will feel that, yes, I could do some coordination work around this young workforce. We have time, I think, Mohil, if I'm right, for one brief question, or do I need to wrap up now?
You can take one question more, then you have to make the concluding remarks.
Thank you. So Ms. Barsha Akhtar, you're the last person. We'll just take a brief question or comment from you, please.
Thank you, sir, for giving me the floor. I'm Barsha Akhtar. Currently, I'm doing MPH on IUBAT, and this is my 3rd semester. This semester, I get a chance to do a course on One Health under Professor Mohibul Islam, sir. So, and this webinar, it was a recall of that one. Since One Health is an interesting topic, it included the human, animal, and environment health. So my question to is, what kind of One Health research is most needed in South Asian contexts, like shared aware about this. So how can young women researchers contribute effectively about this issue?
Sorry, Barsha, to clarify, did you just ask what type of One Health research is most beneficial in South Asian contexts, correct?
Hard for you to answer, isn't it, Sahim, living in the middle of Canada? You know what? It's a great question. And we could spend an entire seminar talking about this. And I suggest maybe we want to think about that for a future public health cafe. There's so many people here. I would love to hear their opinions about this. I mean, Professor 𝗱𝗲𝗯𝗹𝗁 for a start, but so many other people who would have so much to say. Let's put that on hold and a quick comment, Ms. Shagifta Mohammed. Did you want to say something quickly just on this question?
Thank you so much for letting me to speak in this great platform. I would like to thank the organizers for organizing such a session, and also Zahin for a marvelous presentation. Yes, in short, I would like to thank Marianne, sorry, for her explanation about the methodology and advices. Thank you so much. And Morshed sir, for opening our eyes about vector-related diseases. I would like to highlight a little point that Public Health Foundation Bangladesh is organizing Janashastro Mela, that is public health fair. We have already did one pilot and two subsequent project, one in April and December last year. And we are continuing it. Maybe from this year, we might go for more than two fairs a year. It is based in the community level in the rural villages. And there we usually do for 1 day, sometimes for 2 days. We do all sorts of awareness program and health camp, dental health camp, and everything, including related to health, nutrition, and everything. Sessions we organize for 7, 8, 9, 10 grades of students, and also madrasa students. And you could visit our website and our newsletter and our Facebook page, LinkedIn page to look into it. And what I was thinking that we could work with Jahin and also Dr. Morshed, and we could include the animal health awareness training sessions also. And Jahin can organize something that we can include in the 1 day project, something about One Health. And as the information we give to the teachers and to the students, they can deliver it to the society. And it's really helpful. In the last Janashastro Mela, we did the cervical and breast cancer screening, and we did find some positive cases. And people are really accepting it. And the village peoples are very eager to participate and support in every way. Thank you so much. I would look forward to working with you all. Thank you so much.
Thank you as well, Shagifta, for your comments. And this brings to an end, and I think we're very close to our time limit here. You've made thank yous already. I'll just add my own comments. Marianne Morris, Saiful Islam, and Zahin Rahman, of course, Mohiul Islam. Thank you for taking care of moving things forward much better than I am ever able to do. And thank you, everybody, for participating today, and to the people who asked questions and made comments. Very, very helpful, very interesting presentation. Back to you, Mohiul, for wrap up.
Thank you very much. I just express my heartfelt gratitude to you that you have valued this kind of effort, this kind of webinar. We usually sit once in a month, and our Public Health Department Chairman, Dr. Nazmul, he is always behind this. He is supporting this Public Health Foundation and the office bearers of Public Health Foundation. They are all helpful, and they are making their efforts to make this kind of program successful. And One Health is very interesting topic. I like this topic very much. And I think One Health, if it is a bird, then women are one of the wings. Youth people, young, they are one of the wings. So when they click together, they move together, then the One Health journey can start. So we need a lot of coordination and understanding among all the factors. And I really appreciate your participation, your valuable insights and reflections. Thank you so much. And hopefully we'll be meeting in the next month with some other burning issues in the public health. Thank you so much.